So project I've been working on is we kind of don't have we kind of do, but don't have a standardized protocol to the way we image spontaneous intracerebral hemorrhages, especially JHN. As we all know, we're a big facility, yet transferred a lot of these from smaller hospitals or to ED, or even found within Gibbon, they can get transferred if they happen spontaneously. And we overall kind of have come across this, ictal scan, 6-hour scan, 24-hour stability scan. And there's not a ton of evidence out there when you look at, kind of the best way to do this. There's evidence that, if an ICH expands, it will mostly happen in 6 to 8 hours, most of them. There's no standard imaging protocol when looking at hematoma expansion timing. And this, when you talk to nursing, radiology, and you look at it from a multidisciplinary perspective, it's a very burdensome project or a burdensome process for a lot of people. You have to get a tech to help transport the patient from the ICU. It takes, one of the several nurses off the floor for what ends up being 20 to 40 minutes, depending on how long it takes to transfer the patient down, get them onto the CT scanner, get the study, move them back to their bed, and get them upstairs. If the patient's vented or has any other comorbidities, this could become a very difficult process. Not just for those people, but then those resources are pulled off the floor. As a stroke center, we have a lot of people who have use for that, the CT scanner down there. And if we're not needing these head CTs, and I think we get a lot of them, we could really benefit our system by cutting out unnecessary scans if we could identify those. Like I said, it's kind of a lot of people will do an ictal, a 6-hour, and a 24-hour before starting heparin sub-Q. And I think that talking to a lot of people, we have found that that's not necessarily necessary. We just didn't have a great way to identify who needs them and who doesn't. So we looked at over 300 patients with ICHs at JHN essentially, and defined fairly sensitive for hematoma expansion, or I think clinically significant is 33% in the volume or a 6 milliliter or cc increase. So we looked at all these and we essentially risk stratified and checked what patients were at risk for expanding ICH. And we looked at traditional variables that were previously cited in the literature and stuff that we had wondered kind of from our own anecdotal experience. From a quality improvement perspective as well, we kind of talked to the different disciplines about what a non-contrast head CT entails and the resources it pulls from the hospital. We sent out a survey and got over 50 responses detailing what scans people thought were helpful, what scans weren't, how efficient they thought that our head CT process was for these stability scans. And essentially got some good answers on where we could start to target or cut the fat in some of our imaging protocols. So essentially, what quickly became apparent is we had kind of 3 real factors for us in our population that really came out as people who are at risk for expansion. So ICH score of 3, which, as contains several variables, size, GCS, and kind of age and location, so we only did supertentorial for that matter, but it's just important to note that while that it has multiple variables, we found a very strong correlation between the ICHs that were ICH scores that are greater than or equal to 3 for people who are at risk for these expanding and then clinically deteriorating. So those are people that we would not want to miss these stability scans on. A lobar intracranial intracerebral hemorrhage as opposed to a deep or basal ganglia was also significant, and then fluid level within the hemorrhage. So it was nice to find these factors that you could tailor to the individual patient rather than just everyone getting essentially 3 scans within 30 hours. Just a quick blurb from the survey there, you could see that a lot of people estimated that these patients are heavily scanned at 3 scans within 30 hours, which is seems very unnecessary except for very high risk patients. So identifying those factors, we looked at a lot of different things. We looked at the ICH score and GCS. Interestingly, we didn't see any correlation with anticoagulation or antiplatelet, for us as far as expansion. Some of the lab values, blood pressure on admission, all of those things ended up not panning out as being significant. Interestingly enough, even though things like the Interact trial and such had talked about blood pressure management and kind of the few things you do have as a modifiable risk factor previously, we did not note that in our study. So kind of putting that all together, where we are now is we're in the process of kind of getting approval of what would be where you stratify the patient based on low, moderate, high risk, or high risk for intervention to help determine the timing of the scans. I don't think we need to have a strict 6-hour, 24-hour, and there are certainly patients that I think don't benefit from any additional scans, such as the uncomplicated basal ganglia hemorrhages with no intraventricular hemorrhage. So, you're not concerned from a hydrocephalus perspective. You're not really, on much risk factors for expansion, and they have a good exam to follow. You may never need to scan them again, and you could, I think, quite feasibly say, start heparin sub-Q 24 hours after their presentation without needing to rescan them unless there's clinical deterioration. Then the moderate and high risk kind of give a little more flexibility, but the way our hospital works is a lot of times between 4 and 5, we're getting all of our stability scans in the morning so that the team has them for rounds to review and can get an early read on them in the morning. So putting the flexibility in there for a moderate and high risk, a moderate has a little more flexibility and timing that allows you to kind of time it for an ideal time in the morning when, the patient's doing well and you don't have to check a scan right away, but still fit within kind of the protocol and the system that we work in, and still have all the patients being not for convenience, but it's helpful for the team to have all those scans done early in the morning. And then the high risk patients are kind of, there's no way you can really get around with some of these patients, I think, getting the 6 to 8 hour repeat scan. And then there's some things that while we didn't find them significant, I don't think that many attendings in our department would be comfortable not rescanning. A patient that, say, doesn't have brainstem compression but has a temporal hemorrhage and has an exam to follow, I think that a lot of us would still want to see that temporal hemorrhage is stable on the short-term interval, or if there's significant IVH and you're worried about hydrocephalus developing, I think that a lot of people would still want to see that scan short-term. So even though we didn't statistically find those significant with necessarily intervention or expansion, I felt that it was prudent to keep that in the algorithm so that people could get those patients scanned on the short term. So going forward, we want to kind of send this out, and I think this is a great forum to present this, maybe get some feedback as to what people would think about a process like this for our spontaneous supratentorial intracerebral hemorrhages to hopefully limit some scans. And then going forward, we would track and get some feedback to see if we are, in fact, limiting the scans or decreasing the number of unnecessary scans for these patients. So, from a conclusion standpoint, we learned a few of these factors that, for our population, affect the risk of hematoma expansion. I think that I learned that, our approach initially, or what we have been doing for some time, is largely general and not catered towards the individual patient. I think from a resident perspective, having something in place like this forces you to critically think about the patients and think about what would make you scan them sooner, which I think is better for the patient and a healthcare perspective, that you're critically thinking about each of these patients, whether or not it's protocol or not. It forces you to fit them into one of those categories. I think that things like anticoagulation, blood pressure not being significant factors, we thought that was very surprising. But the interesting thing is, in our setting, in our healthcare setting, in our population, these patients present even to a small hospital and they'll get reversed for anticoagulation, starting a cardian drip almost immediately. And I think that given that those modified risk factors are almost standard of care for us to control at this point, maybe why those anticoagulation status and blood pressure is not being significantly driving the hematoma expansion in our population. So I thought that was an interesting lesson, that some of these widespread variables that could be applied to many other kind of quality improvement or specialties, that, you know, your population certainly could differ based on how you treat these patients and what kind of resources you have. The fact that a lot of our hospitals will start them on a cardian drip and reverse them before they even send them to JHN makes those risk factors for expansion, kind of stops them in their tracks, I think, in a lot of cases. So, you know, for us, we're going to need to kind of get the protocol and make sure we get active feedback from everyone and make sure that they would agree with something like that. We could do a trial period and see, most importantly, are we missing anything by cutting these scans out? Are the patients still safe? But then B, are we actually dropping the number of scans as well? And seeing if, you know, this could be something that could be applied after we standardize it for the spontaneous ICHs to other issues like a traumatic hemorrhage, or many other kind of imaging protocols that we do that, you know, makes us feel like we're not missing anything. But if we could stratify these patients by risk, we could probably save a lot of patients imaging of many different modalities down the line. And then, you know, obviously follow up to see people who think that we are getting more efficient. So at this time, if anyone has any questions, feel free to jump in.